Venkatesh, start off.
Do I start, sir?
Yes.
Good morning, everyone. It is my privilege to introduce a distinguished academician and pathologist, Dr. Archana Bhat. Uh, she has done her postdoctoral certificate course in nephropathology. Dr. Bhat is an editor in chief of the Rajiv Gandhi University of Health Sciences Journal of Allied Health Sciences since 2023 and has played a key role in its growth after serving as associate editor for the past 3 years. She is Chief Consultant Nephropathologist at Father Muller Medical College and the architect behind the establishment of its nephropathology unit. Her academic training including nephropathology from the International Society of Nephropathology and an observership under Dr. Mahesh Venkalkunti at KMC Manipal. Dr. Bhatt is also noted author, having written 3 textbooks, including Essentials of Renal Pathology, Gamification of Medical Education. She is also actively involved in medical education, has conducted numerous workshops, and is certified ACME graduate. She also serves on the editorial board of several journals and represents India internationally as a screening judge for the Pat Tweet Awards from the year 2021 to the year 2025. We are honored to have you, ma'am, with such an accomplished and inspirational individual with us today. Please join me with warmly welcoming Dr. Archana Bhatt.
Thank you
Over
so
to you,
much,
ma'am.
Dr. Venkatesh, for the kind introduction. At the outset, I'd like to thank the organizers, KCIAPM Resident Committee, for having given me an opportunity to present few cases which we have seen in renal pathology. I'll share my screen. Yeah,
And please hold the mic close to your mouth.
it's still not clear.
Yeah, the mic has to be close. That's it.
Now it's better.
Yes, ma'am.
Okay, okay. The screen is visible.
Yes,
Slide.
ma'am. Yes, ma'am.
Okay, so we'll go ahead. Very good morning to all of you. Let's get started with this renal path webinar, which will be a case-based approach. And to keep it interactive, we have few polls in between. So I request all the residents to be active and be with me on the same page. So, greetings from Padamula Medical College, Mangalore, where I'm currently working in the capacity of Associate Professor in Department of Pathology. Padamula Medical College is a tertiary care center, 1200 plus bedded hospital situated in the coastal city of Mangalore. So before we get into the case-based approach, a little bit on the basics of renal pathology. So as you all know, renal pathology involves not just light microscopic examination, it also involves direct immunofluorescence at least, coupled with electron microscopy examination. And for light microscopic examination, we have different slides which are required for interpreting renal pathology light microscopically. So we routinely perform hematoxylin eosin stain, then there's sparse stain, MTS stains, silver stain, and if required, Congo red stain. So it's a combination of all these stains for light microscopy along with direct immunofluorescence, which is required for a final diagnosis on renal biopsy. So the first case, a 10-year-old boy presented with facial puffiness and pedal edema. Urine routine examination showed proteinuria of 5 grams for 24 hours, and kidney biopsy was sent for evaluation. So, with this history, what are your possible diagnoses? I request the residents you can scan this QR code and type in your answers. If you're unable to scan, you can go to slido.com and type in that code, that is 2069675. So, are you all able to scan? Are you all with me? Dr. Venkatesh? It's okay. I mean, you're able to scan?
Yes, ma'am.
Yes. Oh. So it's a child, 10-year-old boy, presenting with proteinuria, which is in the, yeah, one answer I got, that's minimal change disease. Am I audible now, Dr. Aditya?
Yes, ma'am.
Sorry about the issue. There was a technical glitch. Okay, so I'm sharing the presentation. I was told that it was there till the Slido slide, right?
Yes, ma'am.
Okay, so we go ahead from this. I think sorry delegates for the technical glitch. So this was a renal biopsy where we saw all normal looking glomeruli. I am there, no, Dr. Venkatesh?
Yes, ma'am.
Okay, okay. So here you can see these normal appearing glomeruli. This is on hematoxylin eosin stain. And in between the glomeruli, what we are seeing, those are the tubules and interstitium. So this is H&E stain. Same thing on higher part. Now here you can further see that the glomerulus shows these capillary loops which are patent and they are lined by single endothelial cell per capillary loop, and in between them what we are seeing the pink material, that's the mesangium. So mesangium looks normal without any increase in cellularity. So normally how we interpret this mesangial cellularity is by looking at the number of nuclei per mesangial area. So if there are 4 or more, then it means there is mesangial hypercellularity. So here mesangial matrix looks normal, the cellularity also looks normal. The capillary loops are all patent. Basement membrane also appears normal. So there's no apparent thickening or any deposition seen in the basement membrane. The Bowman space also looks normal. Then the visceral and parietal lining epithelial cells, they also look normal. Surrounding the glomeruli, what we are seeing is the tubules. So these structures are tubules, and in between there's very minimal interstitium. So normally in renal biopsy, when we interpret, the interstitium is very minimal. Okay, so only when there's any pathology, there is expansion of this interstitium. So interstitial expansion can be because of any inflammation, it can be because of fibrosis, any edema, or any granulomas. So here we are not seeing any of those. The interstitium also looks normal. Tubules also look normal with some mild degree of acute tubular injury. This is on Mason's trichrome stain. Here you can appreciate the blue, red and purple or black colors. Even at the low part and high part both, you can appreciate that the glomerulus looks normal. So are the tubules as well as the interstitium. This is on a silver stain. So we all know that silver stain is mainly used to look at the basement membrane. Okay, so any basement membrane thickening, any spikes, any holes, those are quite apparent on silver stain. So in this, it looks quite normal. So the silver stain also shows us a normal glomerulus and tubules and interstitium. So this was a case of minimal change disease. And here on the immunofluorescence examination, we expect negativity with the entire panel. So for interpreting renal biopsies, we run a panel of markers on direct immunofluorescence, and they are mainly IgG, IgA, IgM, T3, C1q, kappa, and lambda. So to know which is the immunoglobulin that has deposited, and to know which complement is activated, and to know if at all there is a polyclonal or a monoclonal deposition. So this is a routinely done panel for all renal biopsies. So the first case was a case of minimal change disease. Okay, so that brings us to how to report a renal biopsy. So most of the centers do not have the provision of this renal biopsy. So I thought I'll just put in a little bit on how a renal biopsy report is reported. So it's mainly with respect to the compartment. So that we don't miss out on anything, we follow this. So firstly, you have to look at the glomeruli. Actually, you are supposed to count them. That's because we know that there is something called focal pathology and a diffuse pathology when we deal with renal biopsy. So focal term is used when less than 50% of the glomeruli show the pathology, while the term diffuse is used when more than 50% of the glomeruli show the pathology. So focal disease versus diffuse disease. Similarly, there's something else known as segmental versus global. So now segmental, this word is used when only a part of the glomerulus shows that particular pathology. Whereas global, this term is used when entire glomerulus shows that particular pathology. So glomeruli are mainly looked for any cellularity, then basement membrane thickening, any deposits, any crescents, any double contoured appearance, any sclerosis, any adhesion. So these are the things that we look for. Then the next compartment that we look is tubules. So in this particular compartment, tubules, we look at the tubules, whether they are normal, whether they are showing any evidence of acute tubular injury, whether there's any evidence of tubular atrophy, any cast present, any fractured cast seen if at all within the tubules. These are the common things that we look for. And when we look at the interstitium, I already explained to you. So we look at whether there's any interstitial expansion, any edema, fibrosis, any inflammation, any granulomas, eosinophils, all these. Then we look at the vessels for any changes, a thickening of the intima, media, then any evidence of vasculitis, any arteriolar hydinosis. So these are the things that we look when it comes to the vessels. Then next is, so I told you, is the immunofluorescence. So in immunofluorescence, we run the panel and we look at the area of any deposits. So if at all, if we see any deposits, we see whether they are present in the mesangium or along the capillary walls or within the tubules or interstitium, anything. And then we also look at the nature of those deposits, whether it's linear versus granular deposits. Then we also look at the intensity. And usually it's graded 1 plus to 3 plus based on the brightness of the deposit. So this is from the manual I've put in here to highlight the utility of all the special stains that we use for interpretation of renal biopsy. So here you can see for the basement membrane on pass it appears purple to bright pink. On Jones or silver stain it takes up a black color. Mason's trichrome it appears blue. So similarly even the mesangial matrix it also has the similar staining properties as that of the basement membrane. Interstitial collagen, particularly the Mason's helps, where this interstitial collagen takes up a light blue color. If there are any immune complex deposits, we know we rely on immunofluorescence for interpreting those, but sometimes even on Mason's trichrome they appear red, so it's not very sensitive for picking that. If there are any incidative lesions, they appear purple, so pink. At this part, you can make out that we are seeing some glomeruli here. Okay, the pointer is pointing towards the glomeruli. And at this part, if you appreciate, you can see that the capillary loops are not showing much of lumen. Okay, it looks like the entire glomerulus is appearing slightly pink and hypercellular. And in the tubules interstitium, if you see, you can see some areas with tubular atrophy along with some interstitial fibrosis. So let's go to the high part. So this is the closer view H&E stain of one glomerulus. So where you can see there is hypercellularity. If you just recollect the previous case glomeruli, where you could see patent capillary loops. But here you're seeing just pink material along with nucleus, which means there is some hypercellularity which has resulted from proliferation mainly of the mesangial cells. So you're seeing a Uh, Sorry for the issue. Y'all can hear now? And is the screen PowerPoint visible? Dr. Venkatesh?
Ma'am, the screen is not visible, but
Okay.
yes, ma'am.
Audio is there, no?
Yeah, audio is there, ma'am. Audio and video both are there except for your screen, ma'am.
Now,
Yeah, now it's visible, ma'am.
so we had any answers for that previous case in the chat?
No, ma'am. No, ma'am.
No. So, delegates are there with us?
Yes, ma'am.
Okay, okay. So the previous case, we thought there was a mesangial-proliferative pattern like I explained to you. Okay, so we could see some mesangial hypercellularity in most of the glomeruli, and this is an immunofluorescence image now. So here you can see two gloms are seen in the field, and if you look into the glomerulus, you can see there is bright staining. Okay, and this is a granular sort of deposition. So with respect to IgA, so this is for anti-sera to IgA. This is kappa, not really strong. Lambda was quite strong. So this is the case of IgA nephropathy. There is a bright granular positivity with anti-sera to IgA, kappa a little, and lambda was strong. So that's one clue. Generally, when we are dealing with IgA, the lambda is generally more bright as compared to kappa. So this is case of IgA nephropathy. And whenever we are reporting renal biopsies for IgA nephropathy, we follow a coding or a grading system. That's the Oxford system. So as per the Oxford system, there's adequacy criteria. They say a minimum of 8 glomeruli have to be seen in order to have this diagnosis and the categorization proper. And it's reported under the MEST-C scoring criteria. So M stands for mesangial hypercellularity, E stands for endocapillary proliferation, S stands for sclerosis, T for tubular atrophy, C stands for crescent. Now, based on the grade, we have different scores like M0, M1, where the mesangial hypercellularity, if it is diffuse, it's M1, if it's focal, it's M0. Actually, there's a mesangial score which is assigned for each glomerulus, and the average of those scores is taken and then finally interpreted. Then E stands for endocapillary proliferation. So if there is a proliferation, it's E1. If there is no proliferation, S for sclerosis, same S0, S1. T stands for first tubular atrophy. So based on the first N, it is assigned like T0, T1, T2. T stands for crescent. So here we score only for the cellular and fibrocellular crescents. The fibrous crescents are not taken into account. Okay. And another clue here we had was lambda was stronger than kappa. Okay, so this is case of IgNF. So we've seen minimal change disease, then we've seen a case of IgA nephropathy. Now moving to case 3. So this was 45-year-old man with nephrotic range proteinuria, and the renal biopsy was sent for interpretation. Okay, so for this, what would you think would be the correct diagnosis, or what is not the diagnosis from the list that I have given here? So the question is, which of the following would not be your diagnosis? The options are minimal change disease, FSGS, lupus nephritis, and membranous nephropathy. You can post your answers in the chat box, and Dr. Venkatesh will uh, read out those answers. So history is this. Okay, 45-year-old man with nephrotic range proteinuria. What won't be your diagnosis from the 4 options that I have given? These are the options. We've got any answers?
No, ma'am, not yet.
Not yet. We have students with us also because of the technical glitch. They all left us.
No, ma'am. I think we do have students.
With the students, you can post your answers in the chat box.
They are posting. Oh, okay, ma'am. Christina says lupus nephritis is not a possibility.
Correct. Right, Christina. That's the answer. Because whenever this presentation of nephrotic, the common diagnosis that we expect are this minimal change disease, focal segmental glomulosclerosis, membranous nephropathy, or diabetic if the patient is a known diabetic. Lupus generally presents as a nephritic picture. Okay? So correct answer. So here we could again see these gloms. Okay, this is on the scanner view. These gloms look okay, which means the cellularity doesn't appear to be increased, and the interstitium looks little abnormal. Okay, we do not see that normal interstitium which we expect, where tubules are back to back arranged. Okay. So there's some inflammation ongoing here. Okay. This is the closer view. So here you can appreciate that the glomeruli do not show any increased cellularity. Okay. And the interstitium here looks quite normal. Okay. So these are the tubules. Tubules also look normal. They are back to back, okay, without any pathology seen in the interstitium. Glomeruli look normocellular, but what we can appreciate at this part is that there is some thickening of the basement membrane and the capillary loops appear a little rigid. So another image, this is on nasal trichrome stain. So here you can appreciate that tubules interstitium look normal, and here the glomerulus you can appreciate the thickened basement membrane. And capillary loops are all patent. So there is no proliferation that is seen. So this is from PA stain, that is per iodic acid shift stain, which again highlights the basement membrane very beautifully. So here you can appreciate some thickening of the basement membrane along with rigid capillary loops. By rigid I mean that they appear like stiff O or D. Okay, that's what we mean when we say rigid capillary loop. And this is the immunofluorescence image for the same patient with anti-serato IgG. So on this, you can make out that there is some granular deposit seen along the capillary walls. So there's granular deposition seen along the capillary walls, which are very bright. That is 3 plus with anti-serato IgG. This is with anti-serato C3. So here again you can see some deposition along the capillary wall, but as compared to IgG, this is a little dull. So this you can see is 2 plus. Okay, so 3 plus, 2 plus positivity, granular positivity with anti-serato IgG and C3 along with basement membrane thickening, which is seen on light microscopic examination. So this was the case of membranous nephropathy. So when we report membranous nephropathy, it can be either primary or secondary. Most commonly, it is primary membranous nephropathy. And in primary membranous nephropathy, there are different antigens which are being discovered now. Okay. Earlier, we used to only look for phospholipase A2 receptor antigen, that is FLAR. Okay. But now there are newer antigens which are being detected. So primary membranous nephropathy can be PLA2R positive. If it's negative for PLA2R, they have to look for other antigens like NEL1 thrombospondin, simaforin 3B, exhaustin, T1, T2. Okay, so these are the different antigens which can be seen in patients with membranous nephropathy. Uncommonly, they can be because of some secondary cause. For example, it could be in association with lupus nephritis. Okay? That's one of the classes of lupus nephritis where there can be membranous nephropathy, or it could be secondary to some medication. But most commonly, what we see is primary. And with discovery of newer antigens now, the term primary idiopathic membranous nephropathy, I think, will soon be obsolete. Because there are different antigens. Even if it's negative for PLA2R, it could be positive for other antigens. And now many centers are working them up further, even if it is PLA2R negative. So with the serum, we can look for PLA2R and thrombospondin 7A. With IHC, you can look for PLA2R and NEL1. The others require further testing. Okay, next, moving on to case 4. This was a 35-year-old lady with nephritic syndrome. Her ANA was positive. The three levels were low. So they wanted us to look for lupus nephritis in this patient. This is the nasal trichrome stain on the scanner view. You can appreciate few glomeruli there. And if you see at the glomeruli, each looks different. Okay, so there's variable involvement of the glomeruli. Whenever we are seeing the glomeruli showing variable involvement, we need to keep these two diagnoses in our mind. One is lupus nephritis and the other one is IgA nephritis. So in these two conditions, it's known. Okay, glomerulus to glomerulus, they look different. It's in between our tubules and interstitium that we are seeing. This is a closer view, HND stain. So here, this glomerulus appears hypercellular. Even this, okay, hypercellular to an extent that the capillary lumina are obliterated. And we can also see some deposits. Okay. This is on nasal trichrome stain. Same to appreciate the proliferation of endothelial cells as well as the mesangial cells. Sometimes you can also see neutrophils or inflammatory cells leading to hypercellular looking glomerulus. This is on a past stain, and here you just compare the two glomeruli. So this looks quite normal with some activity going on here, but this glomerulus shows almost a global proliferation. Okay, so global proliferation mainly by proliferation of endothelial cells and mesangial cells. And moving on to the immunofluorescence imaging. Now this shows a bright positivity with IgG, that is 3 plus, around 2 to 3 plus positivity with IgA, then 1 plus to 2 with IgM, again 2 to 3 plus positivity with C3, and almost 2 to 3 plus positivity with C1. So here it was positive with the entire span, that's a full house. Okay. So this was case of lupus nephritis, where we saw proliferation in almost more than 50% of the glomeruli. So this was reported as diffuse proliferative glomerulonephritis, that's lupus nephritis class 4. So in cases with lupus nephritis or in patients with SLE, why do we do a renal biopsy? One is for establishing the diagnosis, especially in early cases where there's absence of these extrarenal manifestations. Then it's also required for management. Okay, class-wise, the management for lupus nephritis would differ. And it's also important to record the baseline activity. For example, in newly diagnosed or new appearance of any significant marker of renal diseases. So these are some of the indications for renal biopsy in patients with lupus. Now coming to the renal lesions that we can see in case of lupus nephritis, the immune deposits. Yeah, we know that immune deposits we always have to appreciate on the immunofluorescence examination, but in lupus nephritis, they can even be appreciated on this light microscopic examination because of their large size and coarse granularity. Okay, so because of the large size and distribution, they can be seen along the capillary walls or in the mesangium, and they appear as glassy, hypereosinophilic, hyaline-like material with H&E stain, red with MTS stain, pink on Jones, okay, against the black staining mesangial matrix and basement membrane. The other lesions can, other pathological changes that we can see include mesangial and endocapillary proliferation. So they can just be mesangial matrix expansion, or there can be mesangial matrix expansion with increased cellularity. Along with that, there can also be endocapillary hypercellularity, which could be by proliferation of endothelial cells, or it could be because of the leukocytes. Okay? And the proliferation at times can occlude the capillary lumen. And the pathological changes or the proliferation can be diffuse, focal, segmental, or global. So any combination of these which help us in determining the class of lupus nephritis. Now, when we are reporting renal biopsy with lupus nephritis, there is something known as activity and chronicity index or the scoring. This is again required for noting the baseline pathological findings as well as for managing the patient. So here if you see for the activity index, we look at various parameters. For example, endocapillary hypercellularity, neutrophils or karyotypes, fibrinoid necrosis, hyaline deposits, crescent, especially the cellular fibrocellular one, interstitial inflammation. And for chronicity, we look at glomerulosclerosis score, then fibrous crescents, tubular atrophy, interstitial fibrosis. So each of these are given a score depending on the number of glomeruli showing these pathological findings. Okay. And if you look now for fibrinoid necrosis and crescent, the score has to be multiplied by 2. Okay. So the total activity score is from 0 to 24, while the total chronicity score can range anywhere from 0 to 12. So in our reports, we always incorporate these scores as well, the activity as well as chronicity index scores. That was lupus nephritis. Then case 5, here we have a 60-year-old man who is a known diabetic presenting with proteinuria. Renal biopsy was done for. So can I know what do you think could be the reasons for doing a renal biopsy in this patient? Now we know that he's a diabetic and now he's having proteinuria. What could be the reason for doing a renal biopsy? You can put your answers in the chat box. One important reason why the nephrologist do a biopsy in a diabetic patient. Do you have any answers? Dr. Venkatesh,
No, ma'am. There's no answers in the chat.
answers? Anything? Participants, you all can type your answers. So in patients of diabetes, we generally do a renal biopsy mainly when the presentation is not usual or it's not matching the expected course of the disease, or sometimes to rule out any non-diabetic cause of renal problem. Okay? To rule out a non-diabetic kidney disease. That's the common request which is sent with a renal biopsy in a patient with diabetes. So here you can see there are few glomeruli, glomeruli you can see there is mesangial matrix expansion, and the surrounding interstitium is showing some amount of inflammation and some amount of tubular atrophy and fibrosis. Now going to the high part, so this is the glomerulus where you can see mesangial matrix expansion forming a nodule. Okay, so this is a KW lesion, okay, that we see in patients with diabetic kidney disease. This is another glomerulus showing a KW lesion. Okay. So this is a case of diabetic nephropathy class 3. Because if we see any one glomerulus showing us the classic KW lesion, then directly it becomes class 3 diabetic nephropathy. It is basement membrane thickening with mesangial matrix expansion and formation of mesangial acellular nodules. Now this is as opposed to the mesangial hypercellularity which we see in IgA nephropathy. In IgA nephropathy, there is mesangial matrix expansion along with mesangial proliferation, whereas in diabetes, it's just the matrix expansion without any increased cellularity. This is on Mason's trichrome stain. So here again you can appreciate a KW lesion. Okay. This is a silver stain. So here you can see these glomeruli which are showing the KW lesions which appear black or dark in color. Closer view you can appreciate even lamellation sometimes. So in diabetes, we see these nodules which are varying in size. Okay, some are large, some are small sized. They can show lamination. So basically, these are formed because of rupture of those aneurysms and deposition of the material. These two images are from Hepton Star textbook of Renal Path, where I've put these images to show you other lesions which we can see in diabetic nephropathy apart from classic KW lesions. So here you are seeing some glassy deposits. Okay, so these are exudate or hyaline lesions, and even here you can see this is a capsular drop. Similar characteristic staining properties are as this material, but here it's seen just beneath the capsule. So capsular drops and exudative lesions. These are the other lesions which can be seen in patients with diabetic nephropathy. And on immunofluorescence examination, it's usually negative. That's no granular positivity with any of those markers. However, you can get a non-specific staining with IgM or T3 in those areas with sclerosis or mesangial matrix expansion. It's a non-specific stain. Otherwise, it's generally negative. That means no granular deposits seen on the immunofluorescence examination. So this was diabetic nephropathy class 3. So when we are reporting diabetic nephropathy, we use a classification system which is known as Turbot et al. Classification. So in that we give the class of diabetic nephropathy based on looking at the glomerulus. Then we also give a score for the tubules and interstitial changes and also scores for the vascular changes. So KW lesions, these are also known as nodular lesions. It's the accumulation of homogeneous eosinophilic material within the mesangium, often appearing as a rounded accentuation of the mesangial matrix, and they are usually acellular, though you can see the nuclei arranged at the periphery. Larger ones can show lamination like I showed you in those images, and the staining properties of those. They are positive with silver stain. Okay. So whenever we see these sort of nodules in most of the glomeruli, that pattern is known as nodular glomerulosclerosis. So when you get that pattern of light microscopic features, these are the other differentials which can be thought of. So in a patient with known diabetes, it is straightforward case of diabetes, nephropathy. But if patient is non-diabetic, then you need to keep these other diagnoses in mind as well. For example, immunotactoid, light heavy chain deposition, amyloid deposition, sometimes idiopathic nodular glomerulosclerosis, fibronectin or collagen deposit. So these are differentials. Now moving to case 6. This is a 55-year-old man who presented with hypertension, proteinuria and hematuria. V3 levels were low in this patient, and his renal biopsy showed us these features. Okay. Again, here you can clearly make out that there is hypercellularity. So there is hypercellular glomeruli which are showing proliferation of endothelial cells along with lot of neutrophils. Okay, so this pattern where you see proliferation of endothelial cells and presence of lot of neutrophils, this pattern is known as exudative proliferative glomerulonephritis. And when we see this pattern, we usually expect infection related glomerulonephritis. On the immunofluorescence examination, we saw bright positivity with antisera to IgG and P3. And the deposits were seen, so that's in the mesangium as well as along the capillary wall. So this was a case of infection related glomerulonephritis. So after we saw the biopsy, came out with this diagnosis, then actually patient was examined in detail, and he was found to have some skin lesions. Then a dermatology opinion was sought, and then a skin biopsy also was done for those lesions, and this patient turned out to be having leprosy. So this was something different in the sense the patient presented with renal complaint first, and then we found this infection. He had leprosy. So this is infection related glomerulonephritis due to associated ongoing infection, that is leprosy. And it's important for us to know whether it's a post-infection glomerular or a post-infective or infection related, because when it's post-infective, then usually steroids happen. But if it's in ongoing infection, then the infection has to be treated only with antibiotics. So that is important for us. E7, this is a 45-year-old lady who presented with rapidly progressive glomerulonephritis, or in other words, sudden decline in renal function, reduced urinary output, raising creatinine, urea. Okay, so that is the presentation, and this is the biopsy. So on the biopsy, you can see the glomeruli show increased cellularity, and even the intestine is showing some edema. Okay. Let's go to the hyper and see what are the other features we are looking at. So this is one closer view of this glomerulus, and here you can see there is increased cellularity mainly because of proliferation of the parietal epithelial cells. Okay, so this is extracapillary hypercellularity, and if you look at this area where there is proliferation, there are a lot of cells. Okay, so what is the structure we are seeing? It's a crescent. So this appears like a cellular crescent. Other glomeruli, even here you could see a crescent formation. Here you can see almost a circumferential crescent with surrounding inflammation, disruption of the glomerulus or the basement membrane structure. So here we could, in this case, we saw these glomeruli showing crescent, most of them being cellular crescent, partial to circumferential in nature. Another image where you can see this crescent. So when we're looking at crescents, we classify them. Okay? One thing is depending on involvement, whether they are encircling the entire glomerulus or only a part of the glomerulus. So based on that, they are known as partial or circumferential. And based on the appearance, okay, whether they have predominantly all cells or whether they are showing some mixture of collagen and cells or entirely fibrous. Okay? So based on that, they are named as cellular, fibrocellular, and fibrin crescent. So for us, cellular crescents and fibrocellular crescents, they are like a critical value. So when we see these, it's our duty to immediately inform the clinician, okay? Because those are the glomeruli which can be saved. But if the crescent is entirely fibrosed, that clone cannot be saved. Okay, so cellular and fibrocellular crescents, when you are seeing, immediately you have to inform the clinician. And on immunofluorescence examination in this patient, we saw this kind of bright linear positivity with IgG. Okay, so this was the case of anti-GBM disease. T3 also showed that kind of linear positivity. So the light microscopic appearance was crescentic glomerulonephritis, and this is the pattern we expect when we have the history of RPGM, that is rapidly progressive or sudden decline in renal function. The pattern that we expect to see is crescentic glomerulonephritis, and once we see a crescentic pattern, based on immunofluorescence findings, it can further be divided as either anti-GBM disease or immune complex mediated glomerulonephritis, which is having crescent, or when entire panel is negative, then it is reported as quasi-immune crescentic glomerulonephritis. This case, which I showed you now, since it had linear positivity with anti-sera to IgG, this was anti-GBM disease. Okay, if patient has got pulmonary symptoms, then it's good pastures disease. In patients with lupus or infection related glomerulonephritis also sometimes you can see crescent, and there you put it under this basket, that is immune complex mediated crescentic glomerulonephritis. When IF is negative, then this is the basket, that's quasi-immune glomerulonephritis, where you see all the ANCA associated glomerulonephritis. So, to summarize, we have seen different cases, each with a different diagnosis. For example, we started with minimal change, then we saw case of IgA, infection related, and lupus nephritis, anti-GBM disease. So different diseases with different patterns of glomerular injury. Then we also learned in between about the basics, okay, that the different stains that we use, the immunofluorescence panel that we use, the routine reporting system that is used, and some grading and scoring systems also we studied. So that brings us to the end of this case-based approach on renal pathology. If there are any questions, you can type in the chat box, and I request Dr. Venkatesh to read them out. And really sorry about the technical glitch. And if there are no questions, you all can reach out to me also anytime. You can watch the recording. I believe this will be available on the School of Pathology.
Ma'am, Dr. Nitashri ma'am says nice cases.
Thank you, Dr. Niteshri. And thanks to you for coordinating the whole event.
No, I should, ma'am. Actually, on behalf of the organizing team, ma'am, I sincerely thank you for being
Thank
with us today and for sharing your incredible journey and insights on the nephropathology. Your contributions to nephropathology and medical educations are truly inspiring. And hello,
Thank you, Dr. Venkatesh.
and I also thank all the listeners on the webinar, and thank you everyone for participating.
Okay. Thanks a lot. Thanks to the residence committee for having me here.
Thank you, the residence committee. Thank you, Archana Bhatnam, for arranging this webinar, for
I
delivering
can,
this talk. And I want to let all the audience know that this recording will be available
yeah,
for you to
please.
view, go back and view again. So we apologize for the technical glitches though, and I'm sure the recording will be available. And please go have a look at it once you're done in the evening as well. Thank you,
Thank
ma'am.
you, Dr. Aditya, and the entire team of KCIAPM. Thanks
Thank
a
you,
lot.
ma'am.